on in Excel. Okay. What is important in invertogram? Identifying cubic and coxet. Okay. खबर नहीं पड़ क्या अच्छा. So that is line. Where you can localize cubic because bones are not fully developed. Bone pelvis is not developed. So how you can check the line? Beautiful. This is a various form of invertogram. Tell me. कई varieties है. Low variety. बीजामा. High variety. This is radio marker at the location of anal. Anal dimple. If it is not anal opening, there is a anal dimple. यहाँ कुदरत ने proposed site तो आप ही दे सकते. यहाँ आपने anal के नाम बाल लगाने हैं. What is called remember? Thoracic rectum. Sometimes it is high variety. There is a no rectum. It is colon. And we have to do anaplasty. That is very nice procedure. Sometimes it is a pouch colon. There is no ascending descending colon. Only there is a colon. There is pouch colon. Sometimes agenesis, colonic agenesis, colon now. So this can be identified by invertogram. This is cross table invertogram. Now tell me which is more visible. These are invertogram. बच्चा आगे तो मुको यानी कि तो बुलेट का मसाला. Okay, again it is cross table invertogram. In pediatric patients, some anomalies and hypertrophic pylori stenosis, the caterpillar sign. It is not variant study. Simple gas shadow, caterpillar sign. Double bubble sign. Dilated first part of duodenum and stomach. It is due to obstruction at second part of duodenum. Lesions obstructing lesion at the second part of duodenum. Double bubble sign. Single bubble sign, hypertrophic pylori stenosis. Double bubble sign, एक duodenal atresia. Annular pancreas. Duodenal atresia, annular pancreas. Which one? The people bubble sign. Again, duodenal atresia, but at the third part of duodenum, not second part. It can be anywhere. Okay, atresia can be anywhere. Short bubble sign. It is meconium ileus, pneumatosis intestinalis. And pneumatosis intestinalis मतलब gas in the wall of bowel. Gas in the wall of bowel. That is meconium ileus, pneumatosis intestinalis. Again, pneumatosis intestinalis suggests what? Necrotizing enterocolitis or megacolon. Toxic megacolon. Yes, toxic megacolon. So that you can see cervical sign. Adult pneumatosis intestinalis is a very abnormal, very rare. Pediatric one, it is not uncommon. Toxic megacolon and necrotizing enterocolitis is not uncommon. No? Actually, that change is a bachcha. Growth is different in those child. No? Congenital diaphragmatic hernia, it is not an emergency. It is not an emergency. Patient may identify करो. Sometimes there is a hypoplastic lumbar pulmonary aplasia. Pulmonary aplasia है तो patient ने एक नंबर मूव पड़ेगा. First regularize the rhythm, respiration and hypoxia, and then we can do surgery. Pulmonary hypoplasia that occurs in congenital diaphragmatic hernia. Here say chest X-ray. Bowel look in thorax, chest. After surgery, see lung is expanded. So lung is normal. So this is for preoperative action, postoperative action. बीजों पर क्लियर से कंटिन्यू करो. कंटिन्यू कर दियो बराबर. Past money can take. And be in present. We are human being. It was a lesson, but not life sentence. Aku ami life માં એવું થયું છે Present. Now KUD, kidney, ureter and urinary bladder. KUD, X-ray KUD. Kidney, ureter, bladder. So X-ray must have pelvis. X-ray, sometimes it is difficult to differentiate KUD and abdomen. It is not always, but ideally pelvis appears in KUD, pelvis do not appear in abdominal X-ray. In abdominal X-ray, both diaphragm is visible, lower chest is visible. KUD it is not necessary. We equal lumbosacral spine and pelvis because it is the area of kidney. Left kidney is higher than right kidney. What is the level of L1, L2? L1, L2 is the level of kidney. Left is higher than right kidney. And ureter, course of ureter. We ask usually course of ureter. What is course of ureter? In form of radiology, it is started from transverse process of L1 vertebra through or transverse tip of the transverse process of all vertebra to sacroiliac joint थी नीचे in pelvis to ischial spine, ischial spine and medially up to urinary bladder, suprapubic region. How we can describe? In this line, any radiopaque shadow is ureteric stone. In this line, any radiopaque shadow is ureteric stone. Usually it is a compromise. Ureteric stone cannot be larger. And excessive muta now is. If it is large stone, either in urinary bladder or it is in a pelvis. If it is a large stone in the location of the mid-ureter, large stone chair, the level chair, mid-ureter, near the pelvis or sacroiliac joint, what it can be? Large stone at the near sacroiliac joint. It can be unascended kidney. It can be unascended kidney. It can be horseshoe kidney. So this kind of questions can be there in the logical. Okay. So can you see urinary bladder in X-ray? Yes. Grayish. You can identify source shadow. Visible source shadow include real retroperitoneum is clear. If source shadow is not visible, that means there is something wrong with retroperitoneum. Or X-ray is not good. X-ray is not good. So this is tabon calculum, magnesium ammonium phosphate, tabon calculus. It takes shape of pelvic callosal system. Stone in shape of pelvic callosal system. It may not be obstructive. एक नानो स्टोन ऑब्स्ट्रक्टिव हो सके दिस tabon will not be obstructive stone. This is major stent, double J stent. Usually it is placed postoperatively, perioperatively, sometimes preoperatively, endourological for drainage of urine. So one hand is in pelvis, renal pelvis, another hand in urinary bladder. So it can drain the urine and sometimes pass stone, retain stone or small stones. It is PCM, percutaneous nephrostomy with Malabar catheter. Percutaneous nephrostomy means like percutaneous tube is placed in dilated pelvic system, that is hydronephrosis, and radiological, and urine is drained outside. After the picture, so this is a PCM with this stand. એટલે યુરોટમાં સ્ટેન્ડ પણ છે અને મેલેબર કેથેટર છે. So drainage is also outside and inside. Urinary bladder. Okay, so these are the radiopaque shadow in the pelvis. Sometimes in right side it is hemipelvis, right hemipelvis, left hemipelvis, or retropubic region, that we can cause. So it is, what is the characteristic of the urinary bladder stone? These are usually normal side. These are smooth surface, smooth line, and with laminated appearance, onion-good appearance. Okay? Laminated appearance. Okay? There may be small and multiple. Can you get it later? Okay. So how do you, what is primary stone and secondary stone?
Form in blood. Form in blood. Secondary is kidney stone, blood.
बरोबर लॉजिकल है प्राइमरी स्टोन which is formed there, secondary stone ऊपर दिया हुआ है, नीचे दिया हुआ है. Here it is reverse. So primary stone which is formed in kidney and part and retained in bladder. Secondary stone formed on urinary bladder. So that this question is important. Sometimes in Viva you feel that it is an easy question, then it is not easy. We never like to ask easy questions. So, primary stone. Most common stones are primary stone. Most common source of stone formation is kidney. Kidney is a factory. Stone can be passed. Stones are very small size. They remain there. Then concretion develops, calcification, concretion, deposition occurs in stone, and gradually it becomes larger. So that there is a layer of stone. So it appears like onion pillar and layer by layer formation. So that these appear like onion pillar, layer stone, laminated stones. These are primary stones. Secondary stones in case of diverticulum. When there is a diverticulum or distal obstruction. Distal obstruction, bladder outlet obstruction. That causes stone formation. These are secondary. These are small in size usually because they don't have time to become symptomatic first because pathology is different. Here these are silent stone. What are these is a cover neighbor. Unless it is infected and cause cystitis and hemorrhage. Speculated stones. Sometimes observed stones. Observed stones are speculated stone. If it is speculated stone, presentation will be hematuria. Patient present with hematuria. Painless hematuria, it is in kidney. Painful hematuria, it is in liver. Or it is infection. But hematuria will be presentation of observed stone. These are silent stone. Unless it causes this bladder outlet obstruction. Jhan sudhi nahi kar, jhan sudhi silent is it. Or it is getting infected. You didn't get infected, then there is cystitis. Intravenous pyrography. This is again a specialized procedure showing dye in the urinary tract. So it is an intravenous pyrography. So dye is injected intravenously and then sequential X-rays are taken within speculated time duration up to 24 to 48 hours. Depends, kidney is completely excreting the dye. जहाँ સુધી complete excretion of dye ना आता है, जहाँ સુધી photo, so it may take 24 to 48 hours. Okay, and this is sequential. So preparation made by mouth, animal laxatives, renal function test. Bowel must be empty. Gas should not be otherwise it will obscure our vision. Dye is ejected ureograph is 60%. So one bottle of 100 ml. Each 100 ml bottle contains meglumine, amino, diacid 52 gram, sodium amino diacid 8 gram. Contrast medium contains 60 gram, iodine content 29 per 2 gram. Infusion time should not be less than 5 minutes, not much more than 10 minutes. 100 ml mark. 300 to 600 milligram per ml. Adult dose is 50 to 100 ml. Pediatric dose is 1 ml per kg. यहाँ पर तो ठीक है, ये तो चांस. Okay, how it is taken? Scout film at a plain. It is whenever we advise IVP for stone disease, it is always so IVP scout film. And when we do surgery for stone disease, documented say IVP થઈ ગયું છે. It is proven that the stone location is defined, even though we always advise morning X-ray. Morning X-ray કરી પછી જ પેશન્ટ લેવાનું because stone are mobile. તો આ દેખો પ્રેકસ કે નીચે આવી ગયો. So now pelvic stone becomes lower ureteric stone. Incision ऊपर मुकी है, stone नीचे. Latest status of stone. Warming X-ray, हमेशा plain X-ray. To look at the stone, best X-rays are plain X-ray. The eye study is not to diagnose stone. The IVP is not for proving that the stone is there. Stone is already there. IVP is for anomaly of urinary tract. So always, whenever we intended to do any procedure in urinary tract, always preceded by urography. It may be IVP or immunity urography. Because we have to rule out, we have to assume anomalies, urinary tract anomaly and kidney function. Kidney is excreting or not. So function of kidney can be judged and various anomalies can be identified by prior IM. So IVP is compulsory before doing any urological procedure, endoscopic or open. One is a scalp film, so then nephrotomogram, 10 to 15 seconds, arm to kidney time. Another 10 to 15 seconds. एक बार लाइन चेक करिए 15 सेकंड में किडनी में पहुंच जैसे 5 मिनट KOD film, 5 minute film. Symmetry of opacification of the kidney. Nephrogram will be visible. So if opacified, kidney opacified, it is called as nephrogram. मतलब kidney ना parenchyma ना dye है, verma. It is not in pelvic dialysis system. It is called as nephrogram. There is opacification of kidney. Abdominal compression. પછી પેશન્ટ અબડોમન compress કરીએ. Nephrogram આવી ગયું, now dye is compressed, kidney is compressed, dye will excrete in pelvic collection system, mechanical છે. Then pyrographic image. 10-minute film is pyrography. Pyrography मतलब dye is in pelvic collection system. Ureteral bladder image. Release compression. Compression release करिए. 15-minute film supine prone oblique upright. बंदी. बराबर. So it will show ureteral bladder image. Bladder image delay oblique postward. Patient urine pass कराओ. UV junction calculi can be urine patient pass करसे हो तो sometimes it is pressurized है ना. So sometimes if it is uretrocele it can be visualized. Or it is reflux. Reflux can visualize functional ways. These are functional things. We could not diagnose. I need open radiological investigation. Surgeon cannot diagnose. क्योंकि आपने plate आपे से. These plates are for evidence. Diagnosis real time. This is real time procedure. Now is passing, they are seeing, they are observing, and they are reporting. जो है पसी reporting करते हैं. So sometimes only plates we cannot diagnose by plates only. Delay 24-hour film to confirm non-excreting kidneys. If what we can see delayed excreting kidney, non-excreting. Dye is not passing beyond kidney. Jati. Excretion of kidney. So it is non-excreting, non-functioning kidney. Dye remains in the parenchyma of kidney. So we have to wait for 24 hours, sometimes 48 hours. Indication, hydronephrosis, what is in simple terminology, clubbing of calyces. Calyces are concave shape, cup shape. Clubbing मतलब dumbbell shape है ना. तो cup shape, horizontal and dumbbell. Loss of concavity first stage. Loss of concavity first. Straight line. It is second. And then concave, convexity. This is third. So it is ultrasonographic grading of hydronephrosis. It is just clubbing of calyces. Congenital anomalies, horseshoe kidney, it is flower vasa appearance, duplex kidney, double ureterocele, elder leg of cobra head appearance, polycystic kidney, spider leg appearance, retrocaval ureter, reverse J sign with hydronephrosis. These are various signs which with anomalies. Okay. This is flower vasa appearance, horseshoe kidney. So what is the difference in normal kidney and horseshoe kidney? One is the fusion of lower pole. Then pelvic collection system is usually in normal kidney pelvic collection system is medial. medial. Horseshoe kidney rotated kidney way. So pelvic vessel system will outside. Join as you go. So that there is a flower was appearance. Pelvic vessel system is lateral. It is rotated kidney. Usually pelvic vessel system is medial to kidney. Hilum medial way. Hilum is medial. Here kidney hilum is lateral. A difference. And kidneys are low lying. Hydronephrosis in horseshoe kidney patient present with hypogastric lung. Hypogastric lung. Unascended enlarged kidney. Okay? Unascended enlarged kidney and single kidney. Presented with hypogastric lung. There are using CT scan not a damn just hypogastric lung. Okay? This is hypogastric lung. Just open it. And then this is simple mass, malignancy also coming. So, around the single kidney is removed. There was absent kidney, ultrasonography not the. So, this is the importance of radiological investigations. And anomalies, if we can't think about anomalies, we can't see it. And surgery make a lot of kidneys. It is very old incident, Gujarat nature. Only kidney which was functioning, even though these principles are laid upon. Double pelvis and ureter. Bifid ureter, bifid pelvis, double ureter. So there we can identify by IVP. Adder head appearance. नीचे जो ureterosil है, मतलब dilated ureter, lower and dilated ureter. Cobra head of adder head appearance. This is basically ureterosil. Spider leg appearance, polycystic kidney, spider leg appearance. Polycystic kidney and hydronephrotic kidney. Both are enlarged kidney, both are fluid-filled kidney, and fluidous way, cystic cavities way. Differentiate kidney also, cut section karo, specimen. In polycystic kidney, the cysts are multiple and irregular in parenchyma. In hydronephrosis, this is pelvic system. So it is defined. Pelvic system and parenchyma can be differentiated. आदि का तो spacing में differentiate करी सकते हैं. And spacing is horizontally cut section wall, and it is enlarged kidney, and there are cavities multiple on cut section. Because cavities in shape of pelvic system is hydronephrotic kidney. Irregular parenchymal cavities are polycystic. And it gives spider head appearance. Retrocaval ureter, reverse J sign. What is retrocaval ureter? Usually ureter must be anterior to inferior ureter. But sometimes what happens? IVC is anterior to ureter. So it will be PUG obstruction or it is compression. That patient is with hydronephrotic kidney. Hydronephrosis, lumping abdomen. Okay? So reverse J sign will be there. So treatment. It is identified. What is treatment? Like permanent treatment. Digestion you have to remove. Operation, surgery, with surgery. So right thing.
Displacement of ureter in front of the
Just cut the ureter and anastomosis is anterior to IVC. IVC cut કરીને નથી લઈ જવાના. વિલન કોણ છે? IVC. કલ્પ્રિટ કોણ છે? IVC. IVC કપા. રિયલ લાઈફ એવું જ છે ને. તો ureter. It is less risky. IVC નહીં. IVC કાપીને anastomosis કરી શકાય. It has very lethal complication chances. We do not venture it. Just cut the ureter and anastomosis anterior. Like the complicated This is IVP plates. Multiple plates are there. Scout film in which right side, right upper conduit region, there is a radio opaque shadow. That is stone. Stone dekhai hai. Now from third film, guys in pelvis and urinary bladder, full urinary bladder, and then last film is still guys in pelvic system. That means it is delayed excreting kidney. It can happen on the side of stone. Again, various forms of hydronephrosis, hydrourethral. Only hydronephrosis, then obstruction is junction of PU junction. PU junction, stone or stricture. If it is hydronephrosis with hydrourethral, then obstruction is lower level. It will be strong. This is the SFU grading system of hydronephrosis 0, 1, 2, 3, 4. Usually, renal curve is dilated. So, normal, no dilatation, calysis collapse. Calysis visualized in fact. If in IVP, calysis are visualized, that means there is a hydronephrosis. Grade 1